Welcome to the Test Strategy Lecture. My name is Nathan Klein, and in this lecture, we are taking a slightly different approach to preparing you for paramedic school. Instead of medical knowledge, we're going to take a look at how you take the tests themselves and try to offer some helpful strategies to be better at test taking. There are many multiple choice tests that you will have to take throughout this program, so I think it would be helpful to learn and practice effective ways to approach the questions you will see on your section exams, your final exams, your FSDAP exit exams, and especially your National Registry written test. First, I want to credit the inspiration for this lecture. Tanner Jones made a great video on YouTube about understanding National Registry questions. The example questions and concepts are from his talk in 2017. I have added some additional thoughts to the original concept, as well as made this an interactive lecture. The link to the original video is here. With that, let's start with an outline of the two types of questions that you will see on tests in the paramedic program. That is the knowledge or definition questions and the scenario or analytical questions. Definition questions are essentially trivia directly from your textbook. Things like, what is the appropriate depth of chest compressions with CPR, or the appropriate flow rate of a nasal cannula? Really, anything in your textbook can be fair game for this type of question. That's why it's important that you study your textbook intently. Your teachers cannot possibly relate to you the entire breadth of knowledge that is contained within your paramedic textbook. So the responsibility falls to you to make sure that you have thoroughly studied the entire book. I just want to make this clear, there is no substitute for studying your textbook and doing your assignments. All the techniques in this lecture rest on the assumption that you will spend hours and hours studying through the entirety of the program. Thankfully, these questions are very straightforward. You either know the information or you do not. For scenario questions, we will either ask you, based on the given facts, what is wrong with the patient, or what will you do for them? These are the most difficult questions because of the interwoven information and critical thinking that is required. That is why we want the keys for unlocking testing success. These 5 keys will help us come to the correct conclusion while also not second-guessing ourselves. Not all of these keys are found in every question. Some questions only have 1 or 2 keys, but identifying these 5 elements when present will assist you in coming to the correct answer. The first key is primary information. This is information that you should be focusing on. It is related to the immediate emergency. It can be the chief complaint or specifics about the medical history that raise suspicions of a particular diagnosis. The next is hallmark signs and symptoms. These are signs or symptoms that are specific to a particular diagnosis. This is literally a way of giving you the answer without telling you the correct answer. When these are present, it makes answering the question much easier. Studying these signs and symptoms is vital to doing well in testing situations. Keywords and phrases are seen in both scenario and knowledge-based questions. Words like most, least, first, best, or next give you information when it seems like more than one answer could be correct. These keywords can also relate to the flow of assessments, but we will discuss more about that later. Other phrases you might see relate to the severity of the primary information. This would be words like extreme or severe. Empirical findings are measurable, quantifiable information based on evidence. The most common empirical evidence we will see in a scenario question is vital signs. The final key is to locate secondary information. This is also known as distracting information. These are things that don't relate explicitly to the primary information or the treatment of the patient. Before we get into examples of how to use these keys, I want to remind you of some other general strategies when it comes to test taking. First is the importance to never add information to a question that isn't explicitly or implicitly stated. Questions will have information that is directly stated. For example, the patient's pulse is 62 beats per minute at the wrist. This can lead to implicit information, such as the patient has a palpable pulse. The problem comes when we jump into the assumed information like the pulse is regular. So stay in bounds of the information given. Some more things to remember about giving multiple choice tests are to always read questions and answers carefully. Remember that a partially wrong answer is always wrong. We often choose the wrong answer because we don't fully read what the question is asking or what the answer is stating. Again, the 5 keys we discussed earlier will help us rule out wrong answers. In scenario-based questions, we may see phrases like "you should," followed by a list of answers. This is in contrast to phrases like "after blank, you should," or "you should first." These triggers give you a starting point for your answer. If it's just a "you should," then it's going to ask a more general treatment question. On the other hand, when given a specific trigger point, you should refer to your National Registry skills sheet to think about the steps and the flow of a scenario. You will see as we get into the examples, but this is why it is important for you to be very knowledgeable about the order of a National Registry skills sheet. With the methodology and strategy explained here, let's look at some examples and see how it all fits into practice. First is a quick example of knowledge-based questions. You can see 3 questions that all directly ask the student to relay the information that they will obtain from a careful study of the program's text. The leaf-shaped flap of tissue that prevents the food and liquid from entering the trachea is called the... Our study of anatomy would tell us that the answer is the epiglottis. In the second question, it would give multiple descriptions, one of which would describe the power grip. Knowledge of what that term means makes it easy to pick out the correct answer. The last one asks if the patient knows what adequate breathing is. It might also be phrased to identify inadequate breathing, which would relate to the same information in our textbooks. Now we get into the more difficult questions, that being the scenario-based questions. We're going to go over 10 examples, and in each one, I want you to pause the video, or if you're watching this on Canvas, we have an interactive lecture, so it will pause for you. I want you to identify the 5 keys that are present. You can use a scratch piece of paper to write things down if you like. Make sure to read the entire question and all answers carefully before you choose an answer. Then we will go through the methodology and find the correct answer together. Also remember that the examples in this lecture are all EMT level questions. Let's begin. You are assessing a 49-year-old man who, according to his wife, experienced a sudden, severe headache and then passed out. He is unresponsive and has slow, irregular breathing. His blood pressure is 190/94 and his pulse rate is 50. His wife tells you that he has hypertension and diabetes. He is most likely experiencing A. Acute hypoglycemia, B. A ruptured cerebral artery, C. A complex partial seizure, or D. An occluded cerebral artery. Take a moment to see if you can work it out for yourself. Okay, I have highlighted the keys that are present in this question. First off, we have the sudden and severe headache. This is a clear example of hallmark signs and symptoms. As we continue through the question, you will see how this phrase makes it so that only one of the given answers could possibly be correct. Next, we'll move down. We come to he is unresponsive and has slow, irregular breathing. This is marked as primary information because it gives good differential information about the patient's condition. The blood pressure and pulse are empirical information as they are quantifiable and related to the complaint. The history of hypertension is marked as primary information, while the diabetes is not, and in fact is marked as secondary or distracting information. With the sudden headache and elevated blood pressure, the fact that the patient has diabetes does not factor into the primary complaint. There is also a distinct lack of hallmark signs or symptoms and primary information related to diabetes. By that same token, the history of hypertension does relate directly and correlates with other information provided. We have the keyword most, all in caps, asking what the patient is most likely experiencing. And with all of this put together, you should come to the conclusion that the correct answer is a ruptured cerebral artery. It is also known as a hemorrhagic stroke, and while it may be the more rare type of stroke, it is by far the most deadly. Just to review, a rupture of the cerebral artery causes bleeding inside the cranial vault alongside the brain. This increases intracranial pressure and can result in a rapid death as portions of the brain are starved of blood through the rupture and the increased pressure. The fact that he is now unconscious is an indicator that this event is rapid in onset, which correlates with a hemorrhagic stroke. The slow and irregular breathing, when combined with the hypertension, wide pulse pressures, and bradycardia are all part of the Cushing's triad, which, as you know, is a set of symptoms that are indicative of increasing cranial pressure. The history of hypertension is one of the most common risk factors of a ruptured cerebral artery. With the totality of evidence presented to us, it is clear that the patient is not having acute hypoglycemia, or a complex partial seizure, or an occluded cerebral artery, which leaves us with the only correct answer of a ruptured cerebral artery. Moving on to the second example question, a 37-year-old male is having a severe allergic reaction to penicillin. He does not have an epinephrine autoinjector, and your protocols do not allow you to carry epinephrine on the ambulance. How should you proceed with the treatment of this patient? Should you A, ask the patient if he has any diphenhydramine tablets that you can administer, B, administer oxygen, transport at once, and consider requesting a paramedic intercept, C, remain at the scene with the patient and request a paramedic ambulance, or D, quickly determine if there is any bystanders who may carry epinephrine. Taking a moment to identify the 5 keys and come up with what you think the correct answer is. Okay, remember that not all keys will be present in any particular question. This is an example where only 2 types of keys are present. We have the keyword of severe, which lets us know that this is not just an allergic reaction, but that the patient is in anaphylaxis and that this is life-threatening. What is important in this question is that you immediately identify that the patient requires epinephrine. That's why the very next part is marked as primary information. We are told that the patient does not have epinephrine and that we are not permitted to carry it on our ambulance. This sets up what we have to work with and directs which answer we will go with. You could restate the question as, this patient needs epinephrine, there is no epinephrine available. Then it proceeds to ask, what will you do when no epinephrine is available? This is where you might be tempted to start adding assumed information or playing what if with the information given. What if there was somebody on scene with epinephrine? What if there was a doctor who would be allowed to administer the drug? This sort of thought process may be fun from a creative standpoint, but it is lethal in the testing environment. Without adding anything to the question, we are left with choosing to administer oxygen, transport at once, and consider requesting a paramedic intercept. The first answer, to ask the patient if they have any Benadryl, is incorrect because, from a National Registry perspective, EMTs are not authorized to give Benadryl, nor is it indicated as a first-line treatment in the presence of anaphylaxis. With the answer, remain on scene with the patient and request a paramedic ambulance, we see an example of a partially correct answer. Requesting the paramedic ambulance is correct, with the unavailability of epinephrine at the moment. Requesting additional resources that do carry epinephrine would be the right answer. Remember at the beginning, though, when I said that an answer has to be completely correct. When there are steps in the answer that are not correct, it invalidates the entire answer. Remaining on scene would be incorrect because this patient is experiencing a life-threatening emergency, and we need to provide what treatments we have, aka the oxygen, and initiate transport immediately while also requesting the paramedic resource. Finally, the last answer is incorrect because it violates the 5 rights of medications. We know as EMTs that we can administer epinephrine that we carry or assist a patient with administering epinephrine that is prescribed to them. It is either our drug or the patient's drug. Therefore, answer D is incorrect. This leaves just answer B with the administration of oxygen, immediate transport, and the request of a paramedic response. Our next question is, upon arrival at the scene of a patient with difficulty breathing, you determine that the scene is safe. You enter the residence to find the patient sitting in a chair in obvious distress. Your first action should be A. Ask the patient what's wrong. B. Obtain a set of baseline vital signs. C. Assess the patient's airway status. Or D. Assess the level of consciousness. Take a few moments to work through the key information and choose your answer. Okay, we have highlighted difficulty breathing as primary information. Being the patient's chief complaint, we should consider it primary and what the patient is experiencing unless proven otherwise. Next, we have marked the scene as safe as secondary information. If they had given us any clues to make us think that the scene was not safe, then this would have been primary information. Remember that scene safety is the most important factor in any scene or scenario. In this question, there's no information given that would lead you to believe the scene is not safe. So in this circumstance, the information is secondary. Obvious distress is marked as a keyword or phrase. The purpose here is to relate to you the severity of the complaint. In this case, you have to determine that the difficulty breathing is so severe that the patient is in obvious distress. This is clearly a bad situation. I have also marked first as a keyword. Remember that keywords like first, after, most are all indicators of jumping off points in your NREMT medical assessment. In this case, they want the very next action after what has already been done in the question so far. You can see as we arrive on scene that we have a general impression of the patient. We have not made physical contact with the patient, so if you refer back to your NREMT medical assessment, you'll see that the very next step is to assess level of consciousness. This is a very simple question when you get right down to it, but because we often perform tasks in real life simultaneously, we can fall into the trap of adding information or misunderstanding what the question is asking. In this situation, the question is simply wanting to know the next step after general impression according to the NREMT medical assessment skill sheet. That's why the answer is D. Assessing level of consciousness is the correct answer. For our next question, we have a 29-year-old male complaining of a severe headache and nausea that has gradually worsened over the past 12 hours. He is conscious, alert, oriented, and tells you that his physician diagnosed him with migraine headaches. He further tells you that he has taken numerous different medications, but none of them seem to help. His blood pressure is 132/74. His pulse is 110 and strong, and his respirations are 20 and adequate. In addition to high-flow oxygen, further treatment should include assisting him with his migraine medication and transporting without lights and sirens, place him in a supine position and transport with lights and sirens to a stroke center, applying a warm compress to the back of his neck and transporting with lights and sirens, or dimming of the lights in the back of the ambulance and transporting without lights and sirens. This one has some longer answers, so take some time to read through and analyze this question before answering. This patient's chief complaint is headache and nausea, so because of this, it will be marked as primary information. Making severe and gradually worsening as keywords is important, as these words relay to us the importance of this complaint. We recognize that while the complaint has been getting worse over the past 12 hours, the patient is still conscious, alert, and oriented, so we have marked this as primary information. Subsequently, we have also identified the diagnosis of migraine headaches by the patient's doctor as primary information as well. While we should never assume that this patient is in fact having a migraine headache, it is important to consider the probability that due to the patient's history of diagnosed migraines and the fact that the patient's presentation is in line with the presentation of a migraine headache, that this patient is likely having a migraine headache. The fact that the patient has taken numerous different medications is a great example of how distractors are placed in the question. It doesn't make any difference in how we treat or identify the patient's complaint. It is good information to gather for our report, but in the context of a test question, it is a distractor. The patient's vital signs are marked as empirical findings. We see that his blood pressure is fine, his heart rate is a little fast, but strong and definitely within the expected values of a patient in pain. The respirations are normal, and importantly, we see the word adequate, which is a descriptive term indicating that the patient does not require any ventilatory assistance. Now, unlike the last question, where it asks what the first action would be, here it isn't giving you a starting point, but simply saying, in addition to high-flow oxygen, what other treatments would you provide? So with that information, you should have picked dimming the lights in the back of the ambulance and transporting without lights and sirens. With the history of migraine headaches and findings that are consistent with those headaches, you should have come to the conclusion that your patient is experiencing a migraine headache. There are no findings that would lead us to believe that this is a stroke of some sort. The first answer is incorrect because it has us assisting the patient with taking their migraine medication. We do not have the protocols or knowledge base to assist the patient with administering their migraine medication, so this causes A to be incorrect. While the placement of the patient is not an incorrect answer, and the patient could find supine to be a position of comfort, it is the manner of the transport and the destination that makes this answer incorrect. Use of lights and sirens would exacerbate the headache, as migraine patients often have light and sound sensitivity. Further, there is no indication for transporting a migraine patient to a stroke center. Finally, with C, while the warm compress is not explicitly a wrong answer, I should note here that most people with migraines tend to prefer cold or cool compresses over warm. It is the transporting of the lights and sirens that makes this answer incorrect for the same reason as answer B. Question 5 says, you are transporting a 42-year-old male who's experiencing blunt abdominal trauma. He is receiving oxygen at 12 liters per minute via a non-rebreather mask, and full spinal precautions have been applied. During your reassessment, you notice his level of consciousness has decreased and his respirations have become shallow. You should A, perform a comprehensive secondary assessment to determine why his clinical status has changed, B, insert an airway adjunct if he will tolerate it, and begin assisting his ventilations with a bag mask device. C, reassess his vital signs, then notify the receiving hospital of the change in his clinical status. Or D, suction his oropharynx to ensure it's clear of secretions, then increase the oxygen flow rate to 15 liters per minute. Take a moment to analyze and answer this question. In this question, we see we are dealing with abdominal trauma. We have marked the abdominal trauma as primary information. We have also marked the fact that the patient is already receiving 12 liters per minute of oxygen via a non-rebreather mask. We see that the patient is in spinal precautions. And at the same time, we see no indication of why the patient was placed in spinal precautions. We mark this as secondary information because, as you will see, this question has nothing to do with the possible spinal injury. We marked as keywords and phrases the descriptors that the trauma is blunt as opposed to penetrating. And we have marked that mental status has decreased and respirations have become shallow. These are key indicators that the correct answer is B. Insert an airway adjunct if he will tolerate it and begin assisting his ventilations with a bag mask device. The key to this question is that last phrase, respirations have become shallow. This indicates a decrease in tidal volume, which will lead to life-threatening hypoxia. It is always good to remember that any time a question denotes inadequate breathing, this indicates a decrease in tidal volume, which will lead to a life-threatening hypoxia. It's always good to remember that any time a question denotes inadequate breathing, that this is a life-threatening issue, and you should be on high alert for answers that address this. It is also important to distinguish between the supplemental oxygen that the patient is already receiving and assisting with ventilations. The extra oxygen is useless if the patient is not breathing deep enough to move that oxygen past the dead space of the lungs. Answer A is definitely something we would want to do, but it isn't the definitive answer for his imminent problem. Answer C also fails to address the lack of adequate ventilations, while answer D is wrong because there is no information that is explicit or implied that would suggest that the patient's airway is occluded. This is another example of adding information to the questions, and it again leads you down the wrong path. In our next question, we have a 26-year-old female presenting with heavy vaginal bleeding. She is conscious but restless. Her blood pressure is 84/54. Her pulse is 120 and weak, and her respirations are 22 with adequate depth. She tells you that she inserted a tampon about 2 hours ago. You should A. Administer high-flow oxygen, ask her to remove the tampon, perform a detailed secondary assessment, and transport promptly. B. Administer high-flow oxygen, perform a detailed assessment of her vaginal area for signs of trauma, place her on her side, and transport. C. Administer high-flow oxygen, place a sterile pad over her vagina, keep her warm, and transport without delay. Or D. Assist her with ventilations via a bag mask device, place one sterile dressing into her vagina, perform a rapid secondary assessment, and transport. take a moment to look over the questions and answers. In this question, the chief complaint is vaginal bleeding. We also see that the patient is conscious but restless, which speaks to the possibility of shock. The heavy keyword is there to reinforce the idea of hypovolemic shock, and if we look at the vital signs which we have marked as empirical data, we will see that this patient is showing all of the hallmark signs and symptoms of shock. Hypotension, tachycardia, tachypnea are all ways the body attempts to compensate for the lack of blood volume which is affecting perfusion. In contrast to the last question, this one advises us that the patient has adequate depth of respirations. This is again one of those keywords, but at least in this case, it is used to advise us that ventilatory support is not necessary. We've marked the statement that she tells you she has inserted a tampon about 2 hours ago as secondary information. This really doesn't have anything to do with her current emergency, and while it is helpful to know that she has placed a tampon, it is a distractor for us finding the correct answer. So with the patient showing hallmark signs and symptoms of hypovolemic shock, we can see that the answer is C. Administer high-flow oxygen, place a sterile pad over her vagina, keep her warm, and transport without delay. Answer A is incorrect because we know from our studies that removing an object from a patient's body from which there is bleeding is contraindicated unless it interferes with the airway or breathing. This answer is a classic example of being almost correct but failing in one portion, which invalidates the entire question. B is incorrect because it assumes that there is some evidence of trauma, which there is not with the information given. Answer D has 2 items of note. First is the use of the bag mask device on a patient who has adequate depth. This patient should definitely receive supplemental oxygen, but does not require ventilatory assistance. Secondly, it says we will place a sterile dressing into the patient's vagina. This is another example of contraindicated behavior. This one by itself could catch people who do not thoroughly read the answers. This leads the third answer, which identifies the need for supplemental oxygen, covering the vaginal area, and keeping the patient warm, which is essential with patients who are suffering from hypovolemic shock, as hypothermia inhibits the body's ability to form clots, and transport without delay. I hope by now you're starting to get the hang of analyzing the questions and coming to the correct answer. A 50-year-old male presents with an altered mental status. His wife tells you that he had a mini-stroke 3 years ago, but has otherwise been in good health. The patient is responsive, but unable to follow commands. After administering oxygen, you should repeat the primary assessment, inquire about his family history, prepare for immediate transport, or perform a head-to-toe assessment. Go ahead and take a moment to highlight the information and decide on the answer. First off, we have marked altered mental status and mini-strokes 3 years ago as primary information. The altered mental status is the patient's chief complaint, and their history of mini-strokes or transient ischemic attacks is pertinent to the complaint, as patients who have had TIAs are much more likely to suffer an actual cerebrovascular accident or stroke. Remember that a TIA is when a clot occludes the blood flow to part of the brain. This is just like a regular ischemic stroke, except that the body is able to break it up and otherwise restore perfusion within 24 hours, and the symptoms resolve spontaneously. Moving forward, we identify the statement, "the patient is in good health otherwise," as irrelevant to the cause and treatment of the patient's current situation, so it is marked as secondary information. We have marked unable to follow commands as hallmark signs and symptoms. This, coupled with the stated history of TIA, is a dead ringer for an actual stroke. We should be very confident at this point that the patient is suffering a stroke, and as you know, there is no definitive treatment in the pre-hospital setting, so our main goal is to recognize and transport the patient to definitive care while supporting the patient's airway, breathing, and circulation. This question has another example of the jumping off point after. In this case, after giving oxygen, what of the listed answers is the next treatment in the NREMT medical assessment? The answer is immediate transport. All of the other answers are things we will do if given enough time, but recognizing that the patient is suffering a stroke and identifying that immediate transport as the goal means that all the other answers will have to wait until we get into the ambulance and start transporting. In the next question, we are treating a 45-year-old woman who was stung by a hornet and has a rash. She tells you She is allergic to hornets and has her own epinephrine autoinjector. She also tells you that she takes medications for hypertension. Her breath sounds do not reveal any wheezing, her breathing is unlabored, and her blood pressure is 154 or 94. What should you do if you're not able to make contact with medical control? A. Administer her epinephrine, reassess her condition, and transport her promptly. B. Begin immediate transport, request an intercept with a paramedic ambulance. Or C. Give her oxygen, transport her to the hospital, and monitor her condition en route. And finally, D. Give her half the dose of her epinephrine in case her allergic reaction is delayed. Now that all the information is highlighted, the chief complaint, which is the patient was stung by a hornet, is marked as primary information. We have also highlighted as pertinent that she is allergic to hornets and has her own epinephrine autoinjector. At this point, it is clear that she's allergic to hornets, she has been stung by a hornet, and that her allergic reaction is so severe that it warrants being prescribed an autoinjector for this allergy. We know that if the patient is showing signs and symptoms of anaphylaxis, then we as EMTs can administer epinephrine using the patient's autoinjector. The history of hypertension is a distractor because while it's good history taking to learn the patient's medications and medical history, it is not contraindicated for the use of epinephrine in an emergency setting. The next sentence has a series of hallmark signs and symptoms, which in this case rule out the hallmark signs and symptoms of anaphylaxis. For a patient's allergic reaction to be considered anaphylaxis, the airway must be involved. If this patient were having swelling to the bronchioles or trachea, then it would be grounds to determine that this patient is having an anaphylactic allergic reaction, and that would be an indication for the use of the patient's autoinjector. So the statement here, the patient's breath sounds lack any wheezing, the patient is absent any labor breathing, indicates that this patient is not having an anaphylactic reaction at this time. The empirical findings of the blood pressure confirm that the patient's perfusion, at least from a blood pressure standpoint, are adequate. This is all there to lead us to the conclusion that the patient is not having an anaphylactic reaction. Finally, we have a keyword asking us, what would we do if we were not able to make contact with medical control? Remember that if we cannot make contact with medical control, we have to fall back on our standing orders. So given our standing orders for treatment of patients, and our determination that the patient is not having an anaphylactic reaction, the answer is C. Give the patient oxygen, transport her to the hospital, and monitor her condition en route. A is incorrect, as it would be inappropriate for us to administer epinephrine without signs or symptoms of an anaphylactic reaction. B is also incorrect, as the patient is not in extremis at this point, and even if the patient develops an anaphylactic reaction, we have the patient's autoinjector available to us to use. Finally, answer D is incorrect, as we are unable to provide a half dose of epinephrine, and it again would not be indicated and is not in our protocols to give a half dose. This question is a little bit tricky as it plays on our persistent training to give epinephrine to patients with anaphylaxis. Thankfully, by now, you should be practiced enough with the keys and other tools we've discussed that this sort of thing should not affect you in your understanding of the problem. Moving quickly on, a man found unresponsive in his bed at home. There is no evidence of injury, and the patient's medical history is not known. The patient's face is cyanotic, and yet the pulse oximeter reads 98%. Which of the following would most likely explain this? Is it A, severe pulmonary edema, B, carbon monoxide poisoning, C, his extremities are cold, or D, increased body temperature? Take a moment and work through this problem. Okay, so here we have again highlighted the relevant information. The chief complaint is unresponsiveness, and right away the question rules out one of the major causes of an unresponsive patient by telling us there is no evidence of injury. Since this question is telling us that this is not a trauma, we need to look elsewhere for our answer. The fact that the patient's medical history is not known to us isn't explicitly useful, and in fact we see in the very next sentence the hallmark signs and symptoms of the patient's skin showing cyanosis, and yet the pulse oximeter reading 98%. And if you remember, pulse oximeters don't actually measure the amount of oxygen in the blood. They only measure the attachment of molecules to the hemoglobin. Because of this, patients suffering from carbon monoxide poisoning, which binds to the hemoglobin 200 to 300 times more effectively than oxygen, will have a high pulse oximeter reading despite very little oxygen actually reaching the tissue because the hemoglobin is full of carbon monoxide. Because of these hallmark signs, we can quickly come to the conclusion that the patient is suffering from carbon monoxide poisoning. Okay, one more question to practice before we're done. You are treating a 40-year-old male with a documented blood pressure reading of 480 milligrams per deciliter. The patient is semi-conscious and breathing slowly, and is receiving assisted ventilations from your partner. You should recognize that definitive treatment for this patient includes A. Oxygen, B. Glucagon, C. Insulin, or D. Dextrose. Take a moment to use the skills we've learned here to answer this question. The primary information has been highlighted, and we see that the patient has a blood glucose reading of 480. This is roughly 4 times the normal level, and as such it represents the patient's chief complaint. We also see the hallmark signs and symptoms of a patient being semi-conscious and breathing shallowly, which again we see those as indicators that will lead up to the management of the patient's ventilations. But in this question, the very next sentence answers that problem for us by pointing out that our partner is assisting ventilations. If you remember back to the beginning, we discussed that scenario questions come in 2 flavors. What is wrong with the patient, and what are you going to do for them? This question is a variation on the latter. In this case, it is asking what the definitive treatment is. For the pre-hospital setting, we should be thinking about hospital-level care, the treatment that will definitively fix this patient's issue. And in that case, the answer is C. Insulin. You may think from the phrase breathing slowly that oxygen would be the answer. If the question had been, you should provide, or which treatment is most needed right now, then you would be right. But this question is checking your understanding of the larger picture in patient care. While you may not be administering insulin in your treatment plans, you should be aware that insulin is the definitive treatment for hyperglycemia. To recap, don't forget to read each question and answer thoroughly to avoid tricky wording or misunderstanding the question. Identify any of the 5 keys found in the question. Don't get distracted by irrelevant information or by adding information that isn't in the scenario. And finally, don't second guess yourself. You've studied so hard to get to this point, and your first instinct is usually the correct one. I hope that you've enjoyed this lecture on test strategy, and I hope that it helps you be a better test taker in the future. Have a good day.